I am Rachel, your host and community manager here at Alloy Health. For those of you who might be new, Alloy is a digital health platform bringing evidence-based menopause hormonal solutions direct to your door. Our mission is simple: to make sure women get the care they deserve during perimenopause, menopause, and beyond. I am extremely excited about today's conversation. We are joined by Dr. Sara Reardon, a board-certified pelvic floor physical therapist and the founder of the V-Hive, an on-demand pelvic floor workout app for pregnancy, postpartum, menopause, painful sex, and pelvic floor strengthening. She's also well known as the Vagina Whisperer on Instagram and TikTok, where she's built an incredible community by breaking down topics most people are too shy to talk about. She's also the author of the national, I hope you can see that, best-selling book, Floored, A Woman's Guide to Pelvic Floor Health at Every Age and Stage. Before we dive in, Dr. Reardon, I want to invite everyone to drop your questions for Dr. Reardon into the chat. I will facilitate those for you a bit later. And because we always want these conversations to feel extra supportive, if you're ready for next steps, we'd love for you to take advantage of today's discount code, which you saw on the banner before we started, Reardon20, for a little extra help along the way. Welcome, Dr. Sara Reardon.
Thanks for having me, Rachel.
So happy to talk. Before we get into some of the nitty-gritty questions women so often have, I'd love to start at the beginning. Can you walk us through the basics? What exactly is the pelvic floor and why is it so important for women's health at every age?
So the pelvic floor is a group of muscles that sit at the very base of your pelvis. So if you can envision that kind of skeleton, those skeleton bones that we all see on, models at the doctor's office, or even our skeleton jammies for our kiddos, at the very bottom of that is a basket of muscles, and those muscles support your organs, including your uterus, your ovaries, your bladder, which holds urine, your bowels, which hold stool. So it's a supportive mechanism for our pelvic organs. In addition, the pelvic floor muscles have three openings, one for urine to exit, one for the anal opening, and then the vaginal opening for vaginal intercourse, menstruation, and birth. So these muscles are keeping everything in, urine, stool, throughout the day, and then we want them to relax when we are going to the bathroom or giving birth. And then they also help support our organs so that we don't have leakage or fecal urgency or prolapse. When we start to see issues in this muscle arise are at certain stages of life, like pregnancy, postpartum, but also menopause and perimenopause, when our hormones are changing, our estrogen and testosterone levels are decreasing, and that muscle gets a little bit weaker with time. So as a pelvic floor physical therapist, PTs like myself work with muscles and tissues and nerves in the body, and I work with this area of muscles and tissues and nerves to really help women better understand their bodies and get kind of the strength and support out of this muscle that they need long term.
It's fascinating to hear, and I don't know why I'm always surprised to hear this, but that there's sort of like the mechanics and the skeleton, the muscle, but hormones affect that as
Yes.
well. So what are some early signs that your pelvic floor might not be working well?
Some of the most common ones that women experience would include urinary leakage. So
Mhm.
it could start as small as a leak of urine with a cough or a sneeze or a jump, but then it can become leakage with an urge to go to the bathroom, or, not making it to the bathroom in the middle of the night, or, full-blown incontinence where you are wearing diapers and pads every day to really function and it's limiting your social activity. Other things are, we don't think about bowel issues as well. So it could be fecal urgency, like staining in your underwear, or inability to get to the bathroom in time and having incontinence of stool, constipation, hemorrhoids, and fissures. Other things like sexual health issues. Painful sex is really common, particularly during perimenopause and menopause, because of the estrogen changes, inability to have orgasms, pain after sex, and then also support issues like pelvic organ prolapse, where the muscles aren't supporting the organs as well, and they start to push into the vaginal wall. So all of these things sound very scary, but some of them, a lot of women experience, 1 in 3 women will experience pelvic floor issues at some point in their life. So they're really quite common. And it's important for women to get the education and the therapy and treatment soon so that they can, minimize the effect on their quality of life.
Can women strengthen their pelvic floor at any age, or is there
Yeah.
a point where it's too late?
It's never too late. I mean, this group of muscles is like a muscle, like every other muscle in your body. It's think of your bicep. When you contract your bicep muscle, you can kind of see it building some strength and you keep working it over time and you see it hypertrophy. The same thing can happen to your pelvic floor. It's just a muscle. It's never too late. It can be strengthened at any age. The one thing that I do caution folks is that not every pelvic floor needs strengthening. Sometimes it needs relaxation and
Mm.
lengthening, and then other times it does need strengthening. So it's important to discriminate between which pathway you need to walk down.
You just reminded me that you bring that point up in your book. Can you expand on that a little bit? Strengthening versus lengthening or relaxing?
Absolutely. So just like every other muscle in our body, a muscle can get tight and tense. So I tend to get that in my neck and shoulders from stress or, being on my computer. And it causes me to get neck pain and shoulder pain and migraines. And then I need to stretch and get some massage to release that tension. The same thing can happen in the pelvic floor muscles. Your pelvic floor muscles can get tight and tense from posture, from clenching your glutes, from exercise, from trauma. And when those muscles get tight and tense, it can lead to things like painful sex, tailbone pain, deep hip pain,
Mm.
difficulty starting your bladder stream or incomplete bladder emptying, and straining with bowel movements. It's like these muscles can't relax the way that we need them to. In that situation, we'd want to work more on relaxation first with breathing,
Mm.
stretching, some internal and external massage, and then see if we need to focus on strengthening the muscle.
So interesting. What's the biggest myth you hear about pelvic floor health that you would want to bust for everyone right away?
I mean, I just kind of mentioned it that, I think when we talk about the pelvic floor, historically, the narrative has been do your kegels. You
Mm.
leak urine, do kegels. Better sex, do kegels. Had a baby, do kegels. Menopause, do kegels. And kegels are just a contraction of this muscle. It's like closing those urinary and anal sphincters and kind of lifting the pelvic floor up. Now, the thing is that one, not everybody needs to do Kegels. And two, saying just do your Kegels is the equivalent to saying, like, oh, I have back pain, and somebody going, oh, just do crunches. You
Right.
really need to take a holistic look at your breathing, your posture, your exercise, your bladder and bowel movements, the strength or length of the muscle. It's much more nuanced than saying do this one exercise. The other thing is, even if Kegels are the appropriate starting point, you can't just sit in your desk chair and do Kegels all day and expect your pelvic floor to get stronger. You
Mm.
need to work this muscle in different positions, like standing, walking, during exercise. We don't leak just sitting in our chairs. We leak when we're running to the bathroom with a full bladder. So we want
Right.
to make sure we train this muscle properly for what we need it to do.
Awesome. I want to get back to sort of everyday symptoms around urinating, pooping, prolapse. Why do so many, you laid this out for us, but if there's anything you want to expand on, why so many women might leak when they laugh, sneeze, exercise, and what can we start to do about that?
So your bladder is an organ that sits on top of, like, inside of this basket. So imagine your pelvic floor is like a hammock and it's kind of supporting these things inside. And your bladder is inside of that hammock. When your bladder is empty, it's like a deflated balloon. And as it starts to fill, it kind of starts to expand. As urine fills it up, it starts to expand and sends a signal to our brain of, hey, I'm going to have to go to the bathroom soon. And then your pelvic floor muscles kind of tighten up to better support your bladder. If your pelvic floor muscles are weak, they can't kind of tighten up to support your bladder as it's filling.
Right.
And if your pelvic floor muscles are too tense, it's like trying to do this to a muscle that's stuck and it can't do this.
Hmm.
So one of the biggest things is not just looking at, I think people often say, like, oh, I have a weak bladder, I leaked, but it's actually you have probably weak pelvic floor muscles. So if you can train the pelvic floor muscles to strengthen or better contract as the bladder fills, then when you cough or sneeze or laugh and there's added pressure, you don't get a leak of urine. The interesting thing is these leaks start small, where it's just a little bit here or there, and then we can kind of brush it off. But with time, with more pregnancies and births, with, again, menopausal and perimenopausal changes, they tend to start getting worse faster, and
Yeah.
leakage doesn't just go away by itself. So it's really important to utilize strengthening, the tips I talk about in my book about, bladder control and proper peeing habits, and even topical hormones to help support the bladder to minimize leaks over time.
Awesome. Thank you. Dr. Reardon, you call progesterone the period and poop hormone. How do hormones affect bowel movements and constipation in particular?
So progesterone is a hormone. It kind of gets a bad rap, but it's so necessary.
So necessary.
I mean,
Yes.
all of them are necessary.
Yeah.
When I talk about hormones in the period chapter of my book, it's really, and I also talk about in the menopause chapter, hormones are a symphony of different chemicals working together in our body. And when one piece of that orchestra is off, like the whole sound is kind of bad, right? And so we need to make sure that everything is really balanced. Progesterone is a hormone that can increase at certain times in our menstrual cycle and certain times in our life. So when you're pregnant, you have really high progesterone because progesterone relaxes smooth muscle. It kind of helps everything kind of just chill a little bit. The reason we need that during pregnancy is so that our uterus isn't contracting. We don't want those early contractions. But what progesterone also does is it causes our digestion to slow down. So your colon is also smooth muscle. And when that gets really sluggish in your colon, you have a hard time pooping. So right before your period, every month, you have a spike in progesterone a couple days before your period starts, and this is when we get bloated and tired, and we get constipated, and that's because of progesterone. So I think it's important for people to know, like, we'll have over 400 menstrual cycles in our lifetime as women. So you could be going through this every single month and being like, I'm constipated, what's going on? And so I
Right.
think it's helpful for women to understand the role that hormones play, so that if you are constipated, it's like, okay, I can, take my magnesium citrate or glycinate. I can make sure I have my squatty potty wherever I'm going to be. I can hydrate and make sure I'm getting 30 minutes of exercise that day to help stimulate bowel movements. Just really giving us the tools to navigate these symptoms, because straining with bowel movements can weaken your pelvic floor. And that's why I talk about bowel movements so much, as I don't want folks straining to poop. I want it to be easy.
I so appreciate hearing about progesterone in relationship to something other than sleep. And
Yeah.
perimenopause and menopause, we focus on progesterone a lot around
Yeah.
sort of being this calming, sedative like hormone. But the fact that it actually is involved in your ability to go and go well and smoothly and easily is so important for women to know. You just mentioned squatty.
Squatty potty. Yeah.
Can you I I have one and I love it, but can you just
Talk about
blow
what that
that out?
is.
Yeah, what that is.
Absolutely. You would think I was a spokesperson for them, but I have no financial relationship. A squatty potty is a stool that you put around your toilet. And when you go to have a bowel movement, you don't need it for urination, but when you have a bowel movement, you put your feet on it. And what that does is it puts you in more of a squatting position to have a bowel movement. That helps relax your pelvic floor muscles. The best position to relax your pelvic floor is squatting. So if you think about giving birth, most women are lying on their backs and their knees are to their chest because they're in the squatting position. If you've ever been to Asia or in nature to go to the bathroom to have a bowel movement, you squat because it helps your pelvic floor relax. So a way to facilitate that in Western bathrooms with toilets is just to put your feet on a higher surface so that you can relax your pelvic floor muscles to minimize straining. All of this is in an effort to help minimize pressure on the pelvic floor. I've seen women who come in with, urinary leakage. They've never even had kids. They're like, why am I leaking urine? And they end up having chronic constipation and they're straining every day to poop. And I'm like, we can do kegels till the cows come home, but if we don't address what's causing some of this weakness, then we're not ever going to get to where we need to be. And that kind of goes back to, like, you can't just do kegels to fix everything. It's a little bit more nuanced of looking at the big picture and then making some small changes.
Yeah, I highly personally, anecdotally will recommend the squatty potty to everybody. It really, when I tried one for the first time, it was kind of miraculous. It really makes that big a difference. So if you don't have one, look one up and invest in one. You just said the word pressure, which made me think of the next question. I don't even know if this has to do with pressure or not. You started to lay it out about weakening prolapse.
Yeah.
how does a woman know she has it or is developing it, if that's even the right terminology, and what to do?
So prolapse is when pelvic organ prolapse is when that hammock of muscles is not supporting your pelvic organs as well. It's typically your uterus, your bladder, your rectum, and it starts to kind of push into the vaginal canal, and then you feel something in the vagina. It could feel like heaviness or pressure in the vagina, like something's falling out of the vagina. You're showering and you kind of feel a bulge at the opening, or it feels like rubbing on the inside. So it's not that your bladder's falling out of your vagina, it's that the bladder's kind of pushing into those vaginal walls because those vaginal walls, which is part of the pelvic floor, isn't supporting those organs as they should. Now, I will say the majority of women who walk into a gynecology office will have some degree of prolapse, particularly if you've given birth. So that is not unusual. I think when it becomes an issue is when it starts moving past the vaginal opening, when it's limiting your activity levels, like you can't run, you are uncomfortable during sex, you can't hike or walk or do things in an upright position because you start feeling that discomfort, or you'll experience things like urinary leakage, incomplete emptying with bowel movement. So it's really important to, my tips for prolapse are like stop straining, making sure
Yeah.
you're not pushing when you pee and poop, make sure you're not like overlifting with exercise, and not breathing properly. To strengthen, you've got to kind of support those vaginal walls. I'm also a huge fan of topical estrogen, particularly during perimenopause and postmenopause, which plumps up those vaginal walls. And then you can get support using a pessary, using kind of compression underwear. I have people who wear Spanx just to kind of give yourself a little bit of support while you're strengthening and improving your muscle tone.
I know women who have had that mesh surgery. I
Yeah,
don't know exactly what the procedure is called, but um, that's been a little wonky, I know, in
yeah.
reports in the news and even reports back from women that it was successful for a while, maybe not so much. So all of what you're saying is sort of like that preventative, avoid that surgery. Not
No,
to say other women haven't had success. I don't want
yeah.
to paint a negative picture. I don't know about it.
No, so I think there's a couple things, and it's interesting because one of the reasons I started my account, the Vagina Whisperer, was I was in clinical practice treating women in my clinic who had this mesh surgery, and the mesh surgery that was put in place to support a prolapse went wrong. The mesh was disintegrating, it was causing pain, it was causing infection. And I thought, like, why weren't they given the strategies to maybe prevent this? And now they're dealing with a whole separate set of issues in a really intimate way. I wish we could just give women education beforehand. So everything I mentioned is a strategy to help prevent it, but also if you're experiencing it, to improve it. And if you have surgery, which many people do, I have patients who go into surgery, you have to put on the corrective kind of lens on the opposite side of surgery. So you can't just have the surgery and go back to straining with bowel movements and not breathing properly with exercise. Really utilizing those strategies after the surgery can help make that surgery more successful, because 30% of these prolapse surgeries have to be repeated. So if we can get more life out of them, that is going to help make a woman more comfortable.
Terrific. Thank you for clarifying that. Is there a time to stop thinking this is normal and like actually seek or get, seek assistance, help, get evaluated by a pelvic floor therapist? Like, how do we sort of like be preemptive?
The time is now,
Mhm.
today. If you're here,
Okay.
it's because you're interested. No amount of pain or leakage is normal. I think that we have a narrative in our culture that like little leaks are okay, or after having a baby or with aging, leakage is kind of just part of the experience of being a woman, or pain with sex is just going to happen as, we get into menopause. And none of that is true. It's information from our bodies that something's not working the way that it should. And we have resources for this. Topical hormones, systemic hormones, pelvic floor therapy, exercises at home. I mean, there's so much that we can do. We're just not proactively given it in our medical systems. And that's one thing I really love. I mean, there's many things I love about Alloy, but it's helping women get the resources they need, making it very accessible because, where I live, there's not a lot of specialists in our area, and making it like, hey, you're not alone. So many women are experiencing this. We don't talk about it, but so many women are, and these are the things that can help. So I think what happens is that we don't address the symptoms right away, and then they kind of start getting worse. And then we feel like, oh, it's too late. I've been
Yeah.
having this for years, but it's never too late. You can always get support.
You've talked a lot about estrogen already, which I can't emphasize enough how important it is to particularly topical estrogen, vaginal estrogen, that women are utilizing it. You refer to it as keeps the ship sailing hormone. Um, say a little bit more about that if you like.
So estrogen is a hormone that specifically for the pelvic floor and the vulva and vagina, estrogen helps plump up those tissues in the area. So there's a lot of estrogen receptors in the vagina and in the vulva. So if you are still menstruating, you can think of that time of the month that you have like this egg whitey, lubrication coming out, and it's because you have a higher estrogen at that time of the month when you're ovulating. And then you can think of when maybe right before your period starts, when estrogen's low and you have like a dry vagina, it's itchy, it hurts to insert tampons, things like that. So estrogen is directly responsible for plumpness, for lubrication and moisture in the vulva and vagina, and also for collagen. We talk a lot about collagen when it comes to other skincare, but estrogen helps create the protein of collagen, which also affects the pelvic floor, the vaginal wall support, all of those things. When we have low estrogen levels at menopause and after, and even during perimenopause, when our estrogen levels are doing this, we get vaginal dryness, thinning tissues, which can cause tearing or bleeding, painful sex, less pelvic organ support, more urinary symptoms like frequent urination or urinary tract infections or urgency. And so using topical estrogen on the inside of the vagina and at the vulvar and vaginal opening around the labia and around the clitoris can really keep those tissues plump, healthy, supportive, in conjunction with pelvic floor exercise. So you can't just do one or the other.
Yeah.
The other great thing is that this is a very local hormone. So a lot of women are still concerned about their risk of breast cancer or their family history, which we want to respect. But these hormones stay so locally that it doesn't really get into your system. And there are also other things like DHEA suppositories, which are kind of a precursor to estrogen, which can be used instead of estrogen. But I am on topical estrogen at 43. I think so many women who, preemptively, if we can start using it, we're helping build our muscle tone and strength early so that when we hit menopause, it's like we're not swimming upstream trying to catch up. Like we've used perimenopause as kind of a runway to prepare for the next couple decades.
Okay, stop the presses for a second. Not only did you just answer my next several questions, so I'm going to leave those alone. You just said something so important that I want to just kind of hover on for a minute. You're using vaginal estrogen at 43.
Yeah,
Many women don't realize, don't know that number one, you can
yeah.
use it when you're in perimenopause. You can have a conversation with a menopause specialist, even about systemic hormones when you're still in perimenopause. By the way, I'm 55. I am still in perimenopause. I just had a period that I announced to everybody on Instagram because I couldn't believe it. But to the women in perimenopause, to women who maybe in their early 40s, maybe even a little younger, I don't know. You are doing something preventative.
Yeah,
And one of the things I love so much that you talk about in your book is your education gave you insight into how to live with a healthy pelvic floor, a healthy vagina from the time you learned it to your last day. And so there's a conflation there, right? Sort of how you have learned to treat your younger pelvic floor than maybe many of us who might be listening today, and also preparing for the sustained health of all of what's going on in that bowl. Can you speak a little bit more about what's okay and when?
yes, and this is such a great question. And again, it's why I'm so vocal about this, is because, yes, there are absolutely strategies to help if you're having an issue, but there's a lot that we can do to also prevent some of these things happening or decrease the likelihood of them happening. And it's the same way that I prepared for birth. Like I had the doula, I did the birth training, I did the birth prep, I did the pelvic floor training, and I'm like, everyone should have this information. with perimenopause, the research is very clear. Like you're experiencing these symptoms up to 10 to 15 years sometimes before menopause hits. Menopause is that one day when you haven't had a period in over 12 months. And so after that, you're actually losing 2% of your urethral muscle strength every single year, which is like why so many women in their later stages are incontinent and leaking urine and stool. But this perimenopause, I mean, as challenging as it is being in that stage, it is this kind of flag that's waving of like, hey, this is what's coming. And I can feel it. I can feel more dryness during sex. You know, I started playing tennis and I made a quick step and I was like, I think I leaked. And I'm like,
Oh,
Sarah,
yeah.
you're the vagina whisperer. You can't. But it
No
went
leaking for you.
but it went to show me that like my body's changing, my hormones are changing. I'm doing a new activity I haven't trained my pelvic floor for, so I have to be on the front side of that. So when it comes to using topical estrogen, the first time I actually used it was when I was postpartum, and I was a long-term breastfeeder, and low estrogen levels during lactation also cause vaginal dryness, thinning, painful sex. So that's when I was first introduced to it, and I knew as a therapist, hey, this is something I can do. And now postpartum, we're having babies later in life where that postpartum period blends right into perimenopause, where we're like, I don't know which season I'm in. And so I think understanding the changes your body can go through, looking for them, doing a mirror check for your vulva, kind of cluing in like, am I leaking? And did it feel like I was going to leak? Is sex drier? And then starting to integrate some of these therapies early instead of waiting for things to get so much worse.
Incredibly helpful. So grateful for your knowledge, your understanding that you're sharing it all with us. I want to take a look at some questions that have come in before I pivot back to questions that I actually received from women who knew that we were going to be speaking to you today. Are there some exercises that support that support GSM that sort of help to alleviate symptoms of the genitourinary syndrome of menopause?
Syndrome of menopause. So genitourinary syndrome of menopause is kind of specifically talking about when you have these, hormonal changes, you get a lot of the symptoms we just talked about: increased urinary frequency, sometimes burning with urination, more leaks of urine. And so treating GSM is a combination of supplementing hormones and also increasing pelvic floor muscle strength. So this kind of goes back to those kegels or pelvic floor muscle contractions, is that you can start kind of working on strengthening that pelvic floor. When we think of strengthening a muscle, it gets thicker, right? Like when we look at that bicep, it's like it gets thicker and we're like, oh, look at that muscle. The same thing happens for your pelvic floor. You can't just rely on, just hormones for that. It's a combination of both. So strengthening your pelvic floor with pelvic floor contractions, but not just quick Kegels. You also need to do longer hold Kegel contractions, holding for 5 or 10 seconds, sorry. Holding, I know, we're going to be exhausted. Holding for 5 or 10 seconds and then relaxing completely. You can't just hold a muscle tight to strengthen it. And then incorporating that into workouts you already do, whether it's Pilates or strength training or bar or even walking. Bring that muscle into other fitness routines that you have. And that's what my kind of whole online pelvic floor workout platform is it's like you're not just sitting in a chair doing Kegels, you're learning how to use this muscle during squats, overhead presses, planks, so that you get more bang for your buck out of your workouts and you're not just like sitting in a chair doing Kegels.
I love that. And please do check out Dr. Reardon's platform. It's fantastic and super helpful to just sort of like daily lifestyle, going about your day, movements and motions to sort of more pointed, particular exercises and things like that. Another question. I'm 62 years old. I had a total hysterectomy at 60. After the surgery, I started to experience bladder leakage upon sneezing and coughing. I use vaginal estrogen from Alloy. I've been told we shouldn't use the estrogen applicator, but for me, the applicator gets the estrogen up there better than my finger can. Is there an anatomy reason that using the vaginal estrogen applicator seems to stress incontinence better than inserting the estrogen with my finger?
No, this is really, so one, when you have a total hysterectomy, what we call a total hysterectomy is removal of the uterus, likely the cervix, but also the ovaries. And when you remove the ovaries, again, ovaries are kind of the factory where hormones are made, and so you don't have that factory producing, even if it's just a little bit of estrogen later in life. And so often prolapse can happen. It's like the uterus is kind of at the top of the vaginal canal, and when you take out the uterus, it's like the top of the tent comes down, right? And so now you've just got the walls. So the bladder starts to kind of go into the weaker walls. You have less estrogen, less support. Now, the only reason sometimes folks don't use the applicator is because the tissues are so thin and sensitive that that plastic applicator can kind of scrape the surface going in, that a lot of folks don't find comfortable. So they may use their finger to insert the cream initially, and then with time, as the tissue starts to plump up and get more lubricated, then you can use the applicator. But there's no kind of pelvic floor concern with using an applicator versus not.
That's great. And I will piggyback off of that and just say, in many conversations I've had, and that question came from someone who's joined us for many conversations, doctors do often say, just use your finger, it's easier. I'm really grateful for the question, because the applicator is a great tool for women who can take advantage of it easily and should.
Yeah.
I appreciate that. This was a question I had, and I'm seeing a few about exercises that women might avoid in terms of pelvic floor health, and when to know that they can try something new, when to not.
So a lot of this is based on, I always say it's not the particular exercise, but it's how you do it.
Okay.
So one of the biggest things, the fundamentals, is learning how to properly contract your pelvic floor, because that's like your foundation. When we talk about our core muscles, we think of only the six-pack muscles, but your pelvic floor is literally the floor of your core. So starting with this kind of gentle pelvic floor contraction, and then building that into whatever it could be, a squat, a lunge, a bicep curl. The number one thing I tell people is avoid holding your breath. So if you're squatting, lifting heavy weights, and you're like, think everybody do that now. You feel pressure down in your vagina, and we're trying to minimize that. We want the opposite of that. We want the pelvic floor to lift up, not push down. So breathing is actually probably the most important thing. And I say exhale with exertion, like exhale when you're lifting, exhale when you're squatting, exhale when you're picking up heavy boxes, exhale when you're pushing furniture. So bringing that exhalation into fitness routines and strengthening workouts is key. The other thing I typically tell people to pull back on or avoid is if a certain exercise is causing your symptoms. Like if you jump rope and you're like, I can jump rope for a minute, but after that I start leaking. I'm like, well, then your tissues and muscles can't handle more than a minute of that pressure. So you build up, you strengthen your pelvic floor more, you maybe use an internal support, you use some topical estrogen, like put those puzzle pieces in place so that you can have more endurance. But if you're having pain or leakage or pressure, that's a sign that your pelvic floor isn't quite in the right state to handle what you're asking it to do.
Thank you. Another question. This person says her OBGYN is stating that the only way to fix advanced prolapse is surgery. Are there exercises that you might recommend, and hormones or other medications that might help? You spoke to this already, but if there's any thread to pull.
The way that we stage prolapse is like 1 to 4. So grades 1 or 2 are kind of above the vaginal opening, or slightly, there may be a little bit outside, but above the vaginal opening. Grade 3 and 4 are what we call eversion of the vaginal walls, where it's below the vaginal opening. So if you were to kind of get undressed and go to the bathroom, the vaginal walls are kind of pushing past the vaginal opening. That is a candidate for surgery. If you were to come in and see me in my clinic, a stage 3 or 4 prolapse is a candidate for surgery, but I still encourage folks to do training beforehand and training afterwards for their pelvic floor, whether that's strengthening, exercise, breathing, minimizing, pushing with pooping or peeing, those sorts of things, because again, something led to that prolapse. There is a large genetic component to prolapse. So if you have a first-line relative, like a mom or an aunt, you just have a genetic predisposition that puts you at risk for getting it. So it's not always avoidable. Your surgeon, if it's past the level of prolapse or vaginal opening is right, it may be a candidate for surgery. And surgery can be great. It helps us get to where we need to be, but I do encourage doing some pelvic floor training in conjunction with that. Just like if you had a knee surgery, you'd go to PT afterwards. I think we haven't thought about that for pelvic surgeries, but women deserve that same care.
Yeah, and you mentioned that earlier, that sort of don't kind of assume post-surgery that it's a one and done. That's still, you need to sort of be working on all the things that we want you to be working on ahead of
Right,
surgery,
right.
to maintain. Is it possible for the pelvic floor to be tight rectally? So chronic constipation, pain when PFPT enters and maneuvers a digit, but normal in the front? And if so, what can I do to fix or retrain the rear pelvic floor muscles?
Absolutely. So what you're describing is, you've got these three openings as we described, the urinary sphincters in the front, the vagina is kind of right behind it, and then behind that is the anal opening. And so kind of these posterior muscles are the ones that we need to relax to have bowel movements. So if those muscles are tight or kind of like clenched tight, you can't evacuate for a bowel movement. You may strain. If you're inserting something like therapy, like during therapy or a wand, it's like really tight in there. So one of the biggest things I tell folks is like, look at your posture. Are you a butt clencher? And the ones
Yeah.
when
Okay.
you're like, I'm in the carpooling and I'm like, and I'm like, okay,
Yeah.
relax your butt, Sarah. Or, you're tense, like because you're running late and you're standing in line somewhere. It's like, just take some of those big, deep breaths to make sure you're not clenching your butt all the time. The other thing is look at your posture. Often when we kind of slouch back or kind of tuck our butt under, we're over activating those posterior muscles. Don't delay the urge to have a bowel movement. If you are like a person like I only poop in my house and you're holding in stool all day, kids do this all the time.
Yeah.
That when by the time you get to the bathroom, it's like the stool's hard, your muscles are tight, and they can't relax well. And then incorporate some stretching and specifically for the glutes and the pelvic floor posteriorly into your day to day. That could look like a deep squat, a child's pose, happy baby pose, using a massage ball or foam roller to kind of roll out your glutes and release them. So all of those things can really help kind of soften those muscles, which it sounds like you're in pelvic floor PT now, but you can absolutely just have tension on the posterior side.
You're making me think about sort of pausing for a moment just to sort of amplify a piece about what you call the female brain. Many clinicians do, and sort of how stress and mood affect the pelvic floor. You've been threading this throughout our conversation so far, and you've talked about breathing exercises and yoga, Pilates, things that sort of support, strengthen, and maybe aren't necessarily as intense as
Yeah.
weightlifting or like heavy running or something like that. Can you just speak about that a bit more? Where you want us to be in relation to all this?
Everything that we do with respect to our muscles and with fitness should be about balance. Like if we do a lot of weightlifting and training and tightening, we should also have some focus on softening and lengthening and relaxing.
Mm.
So it's about balance. So if you're into kind of a higher intensity workout, or you'll know that like your muscles get tight. I mean, I get tailbone pain when I do too many squats. It's because my muscles are tight. So I have to focus on that kind of yoga, breathing, relaxation piece as well. However, the pace of our day-to-day lives, the stress that we feel as women, as mothers, as, look seeking healthcare support and perimenopause and menopause, it can upregulate our nervous system. And we all know that feeling of like this kind of buzzy feeling that we feel. And then what happens when we have tension systemically is that our bodies become tense. We clench our jaws, we get TMJ, we get migraine headaches, and you can also get pelvic floor tension. And I see this a lot even after trauma. I write about this in my book because I'm from New Orleans and we had a big hurricane come a couple of years ago. And after 2 weeks of all these evacuations and the city being closed, everybody came back to therapy and their pelvic floors were like
Wow.
tight because stress affects our body. And so what we often see with pelvic floor tension is that if there is trauma or stress, that we need to kind of take a holistic approach. It could be meditation, it could be therapy, it could be medication, it could be seeing it, whatever the case may be. But I think we also have to kind of look beyond the muscles sometimes because, again, I can release your muscles and massage them till the cows come home. But if you leave there and your day-to-day life, the other 6 days and 23 hours is very upregulated, then it takes more than that 1 hour to kind of really get you some relief.
Thank you for that, Dr. Reardon. Can you address, or I'm sorry, can you go back to progesterone for a moment? So for clarification, it helps, this is what this person is asking, digestion, constipation, pelvic floor muscle tone, and sleep?
So a little bit different, and I'm glad you brought this up because I want to clarify. Progesterone can actually contribute to constipation.
Right.
So times you may experience this, or if you're taking progesterone supplementation, I have a lot of patients who do this, and I say, when you take your progesterone, you might be more constipated. So these are the things you're going to want to do. Stay hydrated, take fiber, take
Yeah.
a stool softener or a magnesium supplement that can help. You take progesterone typically at nighttime because it does make you sleepy. But it's one of those things where, like, if you take it, I have a patient coming in, she's like, my hemorrhoids are terrible, my poops are hard. I'm like, are you taking progesterone? She's like, yeah. I'm like, well, it causes constipation. So you need to balance that with things that can help with that. So I want to clarify that it can cause constipation, and we want to do things to help address it because we know that it's a likely side effect.
Yeah, I was going to ask you, Dr. Reardon, about nutrition, and you touched on this just now. So, a fiber supplement is something I hear about, talk about in support groups often. Getting enough fiber anyway in your diet and on your plate. Magnesium citrate is another supplement that you mentioned. Magnesium glycinate. Is there anything else that we should be aware of? Have on our list of things to talk
To
about?
do.
Yeah.
I think with constipation, it's like there's not one thing that helps everybody. I also have a lot of patients on GLP-1s. Constipation can also be a very common side effect. So I don't think any of these things we need to stop. We don't need to stop GLP-1s. We don't need to stop progesterone supplementation. We just need to help educate women on, hey, if you're taking these, this could be a side effect. Here's what you want to do.
Right.
Even things like getting the squatty potty, making sure that you're staying hydrated, exercise around the days of your shot or the days you're taking progesterone to help stimulate bowel movements. Those are kind of the things we want to be encouraging so that they can manage these symptoms.
Okay. Next question. Can you address frequent urination, particularly at night during
Yeah,
perimenopause, menopause, and what can be done to decrease it? Is it
yeah.
related to what you're talking about?
Totally. And this is one of the early signs of perimenopause that I don't think women realize is a sign of perimenopause.
Yeah.
Like, you're waking at night once or twice now, and you're like, I never used to do this, which sleep disruption is like so, offensive to our days. And, or
Right.
you have to go pee 2 or 3 times before going to bed at night, and you go and only a little bit comes out. A lot of this has to do with the decreased estrogen levels around the urethra and bladder, which are kind of on the front vaginal walls. And also your pelvic floor muscles, when they are toned and working really well, can help quiet the bladder down. So, like, say you've got this really strong urge to pee, I tell people, like, okay, take some deep breaths, quiet that nervous system, and then I want you to do 5 or 6 Kegel contractions because tightening your pelvic floor tells the bladder to chill out.
Hmm.
But if you have weak pelvic floor muscles, you're not going to get that effective communication to the bladder. So the two things I really tell people are start doing some pelvic floor training so that you can kind of contract your pelvic floor, take some deep breaths and try to let the urge go away so that you don't give into it. But also using topical hormones,
Yeah.
like topical estrogen around the front side of the vaginal wall and internally can help plump up those tissues and cause less bladder irritation. So those two things I think are important. And this is where, we talked earlier, Rachel, about like proactively caring
Right.
for your pelvic floor. Like, you're already experiencing some of these symptoms, not realizing that there's things that you can do to help improve them now.
Yeah, absolutely. So helpful. Next question. Could abdominal radiation cause a tightening of the pelvic floor?
Yeah, it can. And, typically radiation to the abdominal wall can be due, it's likely a cancer treatment, so it's not avoidable. But what happens when you have radiated tissue is everything kind of gets scarred
Yeah.
down and tight. So there's certain things called radiation cystitis where it can cause irritation to the bladder. It can cause stenosis or tightening of your bowels, which can lead to bowel obstruction. But it can also cause like a decreased blood flow to the pelvic area and pelvic girdle. To have kind of healthy, coordinated muscles, we need things to contract and relax. We need good blood flow. We need good muscle tone. And when you have restriction from scar tissue or radiated tissue, it can contribute. And nerves, radiation affects nerve function as well. We might not get that same ability to strengthen or contract the pelvic floor. It's working with someone after a cancer treatment is a very kind of different, nuanced experience. Sometimes they can't take hormones or won't take hormones. Sometimes we have to work on, relaxing the tissues before strengthening, but there can absolutely be a connection between radiation treatment and pelvic floor health.
It also sounds like, and I don't know this person's circumstance, but it sounds like seeing a pelvic floor therapist
Yeah.
or through this and then beyond would be quite beneficial.
Absolutely. I mean, it's one of those things where I'm not sure if someone has a pelvic surgery, why they're not getting referred to therapy right away. And I mean, we see men after prostate cancer surgeries and their prostate's removed and they might have erectile dysfunction, they might have incontinence, and so they see a pelvic floor PT. It should really be the same thing if you've had a pelvic surgery or have had radiation treatment in the pelvic or abdominal area. Seeing a pelvic floor therapist can absolutely help if you experience changes in symptoms afterwards.
Dr. Reardon, I said this to you earlier, but one of the reasons I really, really wanted to speak with you and bring your voice and your knowledge and expertise to this community is because, as educated as so many of us are and are listening and reading, we don't necessarily sort of put the hammer to the nail about pelvic floor therapy. And I know you, of all people, are so concerned with prevention and that there is so much we can learn to do now or at any stage, as you laid out, and sort of not get to that moment, that point. You talked about playing tennis or pickleball,
Yeah.
like doing a move that you'd never that you'd never done before, so that sort of having that moment, realizing I need to train my pelvic floor for this
Yeah.
activity.
Right.
Like, we're not, as women in perimenopause, menopause, and earlier, having those conversations with our GPs or our gynecologists. And so then we get to a point of needing acute care. And then there isn't a woman, I'll say this finally, there is no woman that I have spoken to who hasn't seen a pelvic floor physical therapist and hasn't raved about it. Like, raved, hands down, this is the best thing I ever did.
I love that. And I always think about, all the work that I do, I think it comes back to two things. I really listen to what women say. I think that women know their bodies best, and yet we've created this narrative to tell them like leaking is normal or dry vaginas is normal or menopause is inevitable. You just have to deal with it. And I'm like, that's not the case. I mean, there are 3 times in our lives that we have an increased risk of developing pelvic floor disorders, which is pregnancy, after birth, and perimenopause, and I'm sorry, menopause. And every single woman will go through menopause. So I'm thinking, if we know that women are likely to experience pelvic floor issues at these times, why aren't we intervening to say, hey, we need to get them training and education and get them either prepared or, addressing things that are going to pop up, because the likelihood of it happening is the case.
Right.
More women experience urinary leakage than osteoporosis, diabetes, and hypertension.
Whoa.
And think of how much education we get about those things. You get your DEXA scan, do your strength training for osteoporosis, go talk about your blood sugar and get that checked. And yet more women experience urinary leakage than all of those 3 things, and yet are not getting treatment for it. And I think it's a testament that we don't really talk about this part of our body. We're not asked. The research clearly shows if physicians don't ask about it, we're not going to tell them. And I think we've normalized these problems instead of normalize the conversations. And I'm so big about normalizing the conversation so that women can really understand the resources available for them.
Ooh, I'm so glad you said yes to talking to us, Dr. Reardon. Okay, next question. For someone who needs pelvic lengthening and relaxing, are kegels
Yeah.
contraindicated? What
Yes.
exercises or interventions would you suggest?
This is such a great
Yeah.
question. If you have pelvic floor tightness or tension, pause the kegels, because you're tightening a muscle that's already tight. You want to work on relaxation. So some of that goes into doing some big, deep belly breaths or diaphragmatic breathing. You watching your posture. Like, I clench my glutes all day and I sit with my legs crossed. Also, massage internally to the pelvic floor, which we do through the vagina. So you can see a pelvic floor therapist and they can go right into the pelvic floor muscles and kind of press on the side walls, just like you'd have somebody press on your shoulder. There's tools and devices that you can use at home. I kind of walk through this in my book if you don't go see a pelvic floor therapist, or I also go through it in my online videos in the Vhive to show you how to do this technique at home. And then lots of yoga, hip
Mm,
openers, stretching, things that are going to soften and lengthen the hips and pelvis versus keep everything tight. And it's balance. You can still do strengthening, but again, you want to balance that with some relaxation work as well.
terrific. Next, can you use both vaginal estrogen cream and tablets inserts? My gynecologist says that's too much estrogen and won't prescribe both.
You probably don't need both. It's like putting Neosporin and mupirocin on the same cut. Like really, they have the same function. You really want to just go with one dose that's needed for you. So I would choose your preferred method. The other thing I will say is that we say that these local hormones are kind of safer in some fashion because they stay local, but when you start overusing them or you're using a higher dose than what's indicated, it will start to kind of seep into your system and you get like tender breasts or some like, other high estrogen symptoms. So you really only need one.
One or the other, yeah. I had a total hysterectomy, but my surgeon did leave my cervix. Will that help with possible prolapse?
No, the research is really mixed on whether that makes a difference. I think it does. In my clinical practice, I have seen a difference in that. So like it's like you still have a pitch to the tent, right? Like
Right.
everything kind of hasn't come down. And so I think that, from my anecdotal experience, I do think it can help. But the other thing you've got to think about is that you still have to kind of be on the front side of strengthening, not
Yeah.
straining. So, I never kind of guide anyone on what they should do with the surgery. I'm like, that's what your surgeon's for. But I can speak to the pelvic floor implications and what you can think about with respect to um, rehab. The interesting thing is, I've talked with OBGYNs who do hysterectomies and prolapse repairs, and they're like, well, the research says that there's really no, like, it doesn't really make a difference in whether, they have another prolapse later on. And I'm like, but there's no negative side effects. And
Right.
it's not just in supporting the prolapse, it's also improving urinary continence, improving bowel urgency, the inability to the ability to exercise without leakage. So all of these things where there's no negative side effects of training this part of your body.
Right. Terrific. Um, this next question asks, I'm 71, never on MHT. Is it too late? And is it too late for vaginal estrogen?
I would say this is really a conversation to have with your provider, but I do have patients who are older and they are experiencing what's called vaginal stenosis, where the vagina starts to kind of close in. They have some dryness, maybe increased risk of infections, where local estrogen can be beneficial for them. Most people say that they take, MHT systemically, like through menopause, and then kind of maybe get off later in life. But topical estrogen can be till death do you part. So you can take this forever, but I would definitely have a conversation with your doctor. But I do have patients who are on it well into their 70s.
Great. I have advanced prolapse and doctor won't perform surgery until I lose 25 pounds in order to allow surgery to be more successful. I'm 5'9", 205 pounds. How much of a difference would that weight loss make percentage wise? My prolapse is protruding and affects all aspects of my life.
I'm really sorry to hear this. This is definitely something that I think is likely causing some discomfort. There is research to show that weight gain can increase the likelihood of pelvic floor weakness and prolapse. I have not heard of a surgeon withholding a surgery from someone. So I think it's always fair to kind of get a second opinion. I do think weight loss at some point will help the longevity of your procedure. But I think that also when you're uncomfortable with prolapse, like you don't want to exercise, And so it's a little bit of like you're stuck in this gray area of like, where do you go? So I would
Mm,
talk with your medical provider. Feel free to get a second opinion, but there is research to show that even 5 pounds of abdominal weight gain can make someone incontinent versus continent. So it does have a significant impact on our pelvic floor health.
mm. A question that came to me asks, when I sit too long on a bike seat or even just at work, I get shooting pain in my vagina or rectum. Could that be a nerve thing?
Yes. So this is classic. We used to call this cycler syndrome. So when you sit on a saddle, you've kind of got this area between your sit bones where your pelvic floor muscles are, but there's this really specific nerve called your pudendal nerve that courses right through there. And when you sit down on a saddle, it compresses that nerve. So think about when you like hit your funny bone and you get that sharp shooting pain to your pinky, it's the same thing.
Yeah.
So I would probably get a different bike seat, to be honest with you, because you just need to be able to offset the direct pressure. If you sit on a toilet seat and you don't have pain, and you sit in a regular chair or a saddle and you do, it's because of the pressure on that nerve, the pudendal nerve. So I would try either there's specific bike seats for this, or getting a cushion so that there's not so much pressure right on that nerve area.
Okay. Just to those of you who ask specific questions about systemic hormones, I want to encourage you to speak with either your Alloy clinician or your own prescribing physician about those things. I don't want to ask Dr. Reardon those questions whose expertise is so
Outside
specific.
of it, yeah,
Yeah.
absolutely. Thank you.
Here's a question which just came in. I've heard you say that the pelvic floor should be relaxed during intercourse, but I've noticed that my floor is tight and clenched, especially while getting closer to climax. But I have anorgasmia and
Mhm.
have never had an orgasm. Would the clenched floor be why? And what can I do?
This is a great question.
Yeah.
You have two layers of pelvic floor muscles, kind of the outer layer that has the opening to the vagina, and also the muscles that go up to the clitoris. And then you have that deeper layer, which is that basket that I've talked so much about. That outer layer of muscles is rich with nerves. It kind of connects to the clitoris, which is all like over 10,000 nerve endings. It's purely a sexual organ. And when you have an orgasm, those outer layer of muscles fill with blood, reach climax, and then kind of contract and relax in a wave-like motion. Anorgasmia is the inability to have an orgasm, and that can be due to nerves. It can be due to sometimes tight muscles where the muscles get so tight that they're not able to release or relax. Or it could also be due, there's also like a psychological emotional component. Some of the patients that I've worked with, if you have pelvic floor tension, I do encourage you to work on those outer layer of muscles. I also encourage what's called self-stimulation. So whether it's using a vibrator or your hand and taking off that kind of pressure of performance and seeing like what works for you
Yeah.
in kind of an intimate setting. But also 90% of orgasms are clitoral from clitoral stimulation, not internal. And so making sure those outer muscles are kind of relaxed, contracting and relaxing well, you don't have pain or tension in them, is going to help facilitate orgasms. But you're not the only patient. I think that it's like 10% of women have never had an orgasm. So it's a complex kind of scenario. It's definitely possible. I actually have a chapter in the book on this, a section of the book, but you do want to make sure from a pelvic floor perspective that those muscles are relaxed and strong and kind of healthy as well.
Dr. Reardon, you just reminded me, and I know we're getting close to the end. I hope you'll forgive me an extra 5 minutes if it comes to it. There was a post that you did on at the Vagina Whisperer, where you sort of were demonstrating with what looked like a vibrator, but I don't know that it was, and you certainly weren't. There was nothing happening internally, and all your clothes are on, but you were sort of like massaging, I guess, sort of your pelvic area. Can you talk about what that was all about and why we might want to think about that?
Yeah, so I was using a device called a Kiwi, which is it's created by an organization that also creates something called the O-Nut, which are they make hardware for pelvic pain. And this Kiwi device, we teach women to, use it to do kind of perineal massage if, preparing for birth. I was using it in that video to show how to use vibration around a C-section scar to help
Mm,
stimulate regeneration of nerves and also sensation in the area. And a lot of women also have pain with sex. And we train them to use something called a vaginal dilator, which looks like a tampon of different sizes. And using the vibrator on your pubic bone, not on the clitoris, but on the pubic bone, can help kind of distract yourself to relax the opening of the pelvis or the
right.
vagina to insert something. What we're trying to do is help you not associate pain with insertion into the vagina for that specific instance. So if we can kind of have you inserting a tampon, a speculum, a dilator, then you're not going to guard up because you're no longer associating pain with vaginal insertion. what was interesting about that post was that thousands of followers were like, this is too much. I'm unfollowing. And I was like, oh, well, this isn't even like sexual. This is therapeutic. But I think what it showed me was that a lot of folks have no idea what women are experiencing.
People are uneducated.
They
Yes.
have no idea. And my job is to give people the tools that are available and to help guide them if they need support. And I think that to say like, oh, we can't do that, I'm like, oh my gosh, 1 in 4 women will experience pain with sex at some point in her lifetime. Like, that's a lot. That's 25% of women that they're not, it's affecting their relationships, their ability to get pregnant, their self-esteem. And so this may not be for you, but that's okay. But I'm glad that you're not one of those individuals. But for the folks who are, I think we need to be able to say like, hey, these are the things that you can do to help yourself, because pelvic floor therapy is not available to everyone for a variety of reasons. We're working on that. That's what the book is for. That's what the V-Hive is for. But I think it was just kind of a mirror as like, oh, people don't have any idea what women are experiencing behind closed doors.
Yeah, I so appreciate, I'm glad I asked the question because it gave you a minute to sort of amplify how important education is.
Yeah.
You also, though, sort of segued to my last question, really, which is for anyone who cannot access a pelvic floor therapist or is even sort of overwhelmed by all the information, what can they start to do like today? Like the 2 or 3 things that they can, take action on today and ongoing.
I think that one, I'm so grateful that you all are here to give an hour of your time to learn about your body, to take care of your body, I think is so important. And that is a great first step. The wonderful thing about medicine now is that you have options. It used to be only seeing an in-person provider was the way to access care. And sometimes that was costly and had long wait lists. So now you have telehealth. Obviously, Alloy has amazing resources. There are online sessions that are available. I have a therapist who does them for me, but there are, other kind of telehealth platforms. There's my book, Floored, which is a really easy kind of first step. I think it's, not everyone is ready to talk to someone about this. So I
Yeah.
think learning about your own body is a first step, and kind of being like, oh, do I need help, or should I try some of these things at home first? And then you can also check out my online platform, the V-Hive. Everybody gets to try it for free for a week. And it just gives you like tons of videos on menopause, perimenopause, strengthening your routines, pelvic floor exercises, painful sex, and just helping to make this information and these exercises very accessible, very affordable, and less stigmatized. I think it's just, again, having these open conversations is key.
Dr. Reardon, thank you so much for being here. I please say you'll come back and speak with
Of
us.
course.
Your wisdom is just immense, and I certainly learned a lot. I'm sure everyone listening did today as well. For those of you watching, if you don't already have it, please do grab this book. It's like it's phenomenal. It really, really is. It's an important book every woman should have. Hands down, full stop, whether you are not yet in perimenopause, you're perimenopausal, or you are in full menopause. Please do pick up the book. It's smart. It's an approachable guide to understanding your pelvic floor and your body. I do want to remind you all that Alloy is here for you. If there's something you heard today that resonated, whether it's about dryness or painful sex, bladder changes, you don't have to push through alone. You are not alone, as Dr. Reardon reminded us. You can connect with a menopause expert. Please do get your tube of vaginal estrogen. Please do that. If
Yeah,
nothing else, get your tube of vaginal
I
estrogen.
know. Huge fan of that. So yes.
Yes. Thank you so much for those of you who joined us today. Thank you, Dr. Reardon. I am like over the moon that you are now part of the Alloy community.
Thank
Really.
you for having me. Thank you everyone for tuning in, and just again, thank you for the work that Alloy is doing. This is such a great resource for my patients, my clients, and people reaching out to me where something is outside of my scope. I'm like, this is the spot for you. So I'm really grateful that y'all are available as an ally and a resource. So thank you as
Thank
well.
you. All right. Be well,
Take care,
everyone.
everyone.
Talk soon. Bye-bye.